Zero.
Thank you, sir. So, good evening, all. We have talked a lot about ECMO, what ECMO is, how we do ECMO, and how we initiate, what problems we face. So many things we have discussed. Now we are moving to one of the most important topic is the weaning ECMO. Because once you have placed ECMO, you should start thinking of how to remove this ECMO. What is our destination? What are the possibility, and how we wean and how we remove the ECMO from the patient. So I have nothing to disclose, and my objective will be to talk about something about the definition of weaning and trialing off, how do we decide the criteria, what are different protocols, and will we decannulate, and how do we decannulate. So weaning is nothing but gradually reducing the ECMO support and allowing body to participate. Whether if it is the VV ECMO, then the lung has to participate in the gas exchange. And when it is a VA ECMO, the cardiac function should be able to sustain the cardiac output and maintain the hemodynamics. This is done over the hours or days by reducing slowly and keeping a close vigilance and monitoring of it. While the trial of that without decannulating, without disconnecting your ECMO circuit from the patient, we completely dissociate the patient from the ECMO support. So, though there is no ECMO support, but still patient is connected to the ECMO, and in cases if there is a failure of our trial, then we can immediately resume the ECMO without any complication to the patient. So this is the difference between the weaning and trialing off. Again, the trialing off also can be ranging from hours to days, depending upon. Usually, the VV ECMO takes much longer time during the weaning as well as during the trialing off as compared to the VA. So when we should think that a patient is to be weaned, so the first thing we should keep in mind that whenever we have put a patient on ECMO, the weaning should be thought by ECMO. So once you have initiated the ECMO, there's the time to start thinking that how I'm going to wean this patient, what will be my strategy, and that will keep changing or keep uh, altering depending upon the patient condition. But at least you should have some roadmap in your mind once you have initiated that. Moreover, the weaning should be starting once the primary problem for which the patient has been put on ECMO, where for the lung condition, if the patient is having severe ARDS, the ARDS is resolving, or if it is a VA ECMO, the hemodynamics have started improving and patient ejection fraction has improved, has myocardial function, myocardial recovery is there, or sometime in a situation there is a ECMO nowhere situation when the disease is irreversible and nothing can be done, patient cannot have any destination. So ECMO, we are in a situation of ECMO nowhere. So that disease is irreversible and that we have to remove ECMO. So we should start. But though this needs to be discussed with the family, whatever method of weaning we are following. At some time, there is a situation where the risk of complication is much higher as compared to any benefit the ECMO support can give. For example, we can take example like if a patient is bleeding massively and the cardiac function has started recovering or the lung functions have started recovering, and we feel that this patient may sustain without ECMO support because you cannot run ECMO for a very long time without anticoagulation. You have to have, except that a VV ECMO is very high. So you have to think and you should start weaning this patient from ECMO when you feel that there is a more risk of having a problem. So what are the prerequisites when we are planning for weaning of a stable patient? Patient should be hemodynamically stable, and as I said, his primary problem should be resolving, though it's not necessarily has resolved completely, but at least the organ should be able to sustain its function. Other organ functions, because so many times it happens, there is a acute kidney injury along with the myocardial dysfunctions or acute respiratory failure or ARDS, or other organs gets involved. So the other organs are also recovering. Or we have decided about the transplant or assist devices, or there is a clinical and lab radiological evaluation has told that the patient has recovering along with the hemodynamic stability and other organ function. That means this patient is can be weaned from ECMO. So is the VA ECMO and VV ECMO weaning is same? No. In all terms, including assessment criteria, how do we wean these patients and how long it takes for weaning of patients? All are different. So we should always plan, think, and execute our weaning protocols according to the type of ECMO what we have, what ECMO support is being given. So when to do this weaning, we can understand the recovery is there, discontinued therapy without recovery, or desperate. So let's take one by one. So what is our optimal goal when we are weaning? Pulmonary recovery has happened in VA, VA. Cardiac recovery has happened. Ventilatory support has been reduced to a minimal and still patient is able to maintain the oxygen saturation. And inotropic support has been reduced significantly. Still patient is maintaining the hemodynamics and tissue perfusion is well maintained. So let's take PV echo vision. When we think of when the native lung is able to participate in the gas exchange above 50%. And this you can see on your day-to-day evaluation that the lung recovery is there. You see radiologically X-rays improving. You see that on the same ECMO flow, oxygen saturation is improving. Initially, a patient oxygen saturation may be 82, 85, and now it is showing 92 or 94. This means that if your ECMO flow has not increased, it means the lung is participating in the gas exchange, and that will be reflected on your blood gas reports. When you look at other respiratory mechanics like lung compliance, airway resistance, those also start showing improvement. And on the moderate setting of the ventilatory setting, at a moderate P, EF ratio is high with a FiO2 of less than 0.5. So because we have to remember that the membrane lung is doing same job what the natural lung does. Natural lung removes carbon dioxide, do an oxygenation with the adequate compliance. Membrane lung, where the oxygenation is maintained by the blood flow, while the CO2 washout or ventilation part of the natural lung is taken care by the sweep gas flow. This we should always keep in mind, and this is what to be considered when we are weaning our patient from ECMO. So indicator, as I said, CO2 has started improving, compliance has improved, resistance has come down, and there is an increase in the end tidal carbon dioxide, especially in the pediatric patient. So when the gas exchange is sufficient with a moderate ventilatory setting, that means this patient is ready for the. Let's see this patient and just think that this is the patient, and it's a very common scenario that you can see the tidal volume is just 51 ml with the ventilatory settings of FiO2 of 0.5 with a 10 P. So this shows that this is a very poor compliance and the lung is generating a very small amount of tidal. So in this situation, this patient is not ready for the weaning. So once you put your patient on VV ECMO, you keep monitoring the compliance every day. You can see here the compliance is just 4.9. So if you keep monitoring this patient, and when you see that this tidal volume, which was initially 30, 40 or 50 ml, now it is improving to 150 or 200 or 250. That means your lung recovery is there and your patient is ready for the weaning from ECMO. So how do we wean this patient who is on VV? You can use the different methods of doing. You can decrease the pump flow up to a certain extent. Yeah, suppose the pump flow is very high, say 5 liter or 5.5 liter, you can come down to 3.5 liter or 3.2 liter. But if you reduce the pump flow further, there is always a more risk of thrombus. Some centers, they reduce the FiO2, which can be reduced. But most of the centers, they reduce the sweep gas flow, because once you reduce the sweep gas flow, even the oxygen content will also start reducing. This is how you can initiate a weaning without reducing the pump flow after a certain extent. You can keep reducing the sweep gas flow. So the proportion of your contribution of the membrane lung will keep reducing. So different tests also performed. You do oxygen challenge test where you do since day one, you increase the FiO2 on the ventilator 100%, and then you do it for 5 minutes, and then you see the PO2 level by doing ABG, and you keep doing it, keep repeating it. That will give you a guide, good trend that how much PO2 is improving. That's what is the oxygen challenge test. And once it reaches above 150 to 200 PaO2 level, it means the lung is contributing significantly and there is improvement, and you need to wean this patient from it. So the pre-test criteria, before we decide that whether there is a failure from the lung, from the weaning trial, whether there is a chance of failure. So disease has reduced, resolution is there, spontaneous breathing is there, and patient is stable. Then we check this oxygen challenge test, and then we do the decarboxylation test where we keep reducing the FiO2 at every 5 minutes step from 100 to 60 to 30 and to 21%. This we do after increasing the ECMO, ventilatory FiO2 to 0.6. And if at any point of time, if there is a drop in the oxygen saturation less than 88%, that means this patient is, or there is a hemodynamic instability, that means this patient is not ready for the beat. Similarly, we keep reducing the sweep gas flow. We start 33%, we reduce whatever the amount, previous amount, we keep reducing it at a 5 to 10 minute interval. And again, if there is a drop in oxygen saturation of less than 88%, that means the patient is not ready for the weaning, and we should look for the causes, and we should treat, we should still wait with the for the recovery of the lung further. And what we observe here, we look at the blood gases, we look at the hemodynamics, we look at the work of breathing of the patient, respiratory rate, oxygen saturation, how much is the urine output, and this is done with the moderate ventilatory setting, means ventilator FiO2 is roughly 0.5 or 0.6 with a P less than 10, and patient is generating a good tidal volume, and patient is maintaining his saturation. So basically, we reduce the ECMO flow to a certain extent, and whenever we reduce, never forget to increase your ventilatory rate, decrease your peak, and maintain a good amount of peak inspiratory pressure. Because initially you were working for the ultra lung protective strategy, keeping your peak inspiratory pressure less than 25, or delta pressure, our driving pressure around 40. Now you have to increase it up to a certain extent, keeping a plateau pressure less than 30. And you keep checking the blood hemoglobin, lactate level. There should not be any tachycardia, bradycardia. And you look at the blood gases, and you do a 2D echo also to look for any RV dysfunction which patient may develop during this time. So what are the possible causes of weaning failure? How do we know? There can be hemodynamic instability. There will be respiratory rate is more than 35, oxygen saturation less than 88, and there is a increased work of breathing. If the patient is patient has a weaning failure, that means we need to resume the full ECMO support and look for a cause, what the possible causes of weaning failure, and we should treat the underlying issues, and then only we should give a weaning trial. So it is possible that the primary pathology has itself not resolved. Our patient has developed some new sepsis, or still patient has not been made adequate dry, patient is in the volume overload, and because of this fluid, patient is not maintaining his saturation. Or sometimes there is a hypokalemia, hypocalcemia, or low phosphate levels, which all has led to a muscular weakness, or there is some nutritional deficiency. And we should never forget that there is a risk of RV dysfunction, and this patient may need a VVA ECMO support or need of a nitric oxide. Our patient has developed some new onset regional wall motion abnormality or some valvular dysfunction. So this is basically about the VVA. Let's talk about the VA. What we look here, this is important. What are the indicators of recovery? Here you have not changed anything parameter, but the cardiac contractility has improved. There is which is shown by the pulse contour. You can see initially the pulse pressure was narrow. Now the pulse pressure has become wide, and you are seeing a very good ejection in your arterial blood line. When you do an echo, there is improved myocardial contractility, and metabolic parameters like lactates and bicarbonates are improving, and there is a reduction in the um, inotropes in these patients. So this is one part that patient is recovering, but there is a possibility that when without recovery we have to do. What are those conditions? When we uh, have initiated ECMO without knowing that patient is having some congenital anomaly, or there is a chromosomal abnormality, or there is some um, severe bronchopulmonary dysplasia, or some non-treatable condition. Our patient has developed intracranial hemorrhage, there is a passive infarction, or there is an uncontrolled disseminated intravascular coagulation. All these are a condition where continuing ECMO may not be beneficial. And here we can always do discontinuation of therapy after consultation and counseling of the patient relative. Or sometimes you need to do a rush weaning in cases of desperate situation like a patient is bleeding massively and there is a chance that you discontinue ECMO, there is a possibility that patient may improve. So how the VA and VV ECMO is different? We talk in the VV ECMO, we look at the lung parameter. Here we look at the cardiac parameter. Here we are looking at the pulse. So there is an increased pulse pressure when it is more than 20. When you look at the mean arterial pressure in an adult, usually it is above 70 with the minimal inotropic support. And you do an echocardiography that shows an improvement in the LV contractility, the ejection fraction above 25%, the mitral regurgitation has reduced or there is a minimal mitral regurgitation, aortic VTI has more than 10, and lateral mitral annular velocity is above 6 centimeters. And when you look at the tissue perfusion, it has improved and is above 70%. And these predictors of the successful weaning from ECMO has also studied. And these three, pulse pressure, improving pulse pressure, aortic VTI, LVEF, and lateral mitral annular velocity, all these have been proven that they are the predictors for successful weaning in the various studies. So how do we do the weaning for the VA ECMO? You look at the etiology has improved and it is compatible with the myocardial recovery. You have achieved the hemodynamic stability. The mean arterial pressure is above 60 or 70 with a low or minimal dose of vasopressors, and the major metabolic disturbances has recovered. So your lactate levels and bicarbonate levels have improved. There is no severe impairment of the pulmonary functions. Your PaO2 FiO2 ratio, if it is less than 100, that means when FiO2 of ECMO has been set to 21%, it means you have to think for the lung again, and there is a possibility if the lung is not functioning well, it means your VA ECMO has to be switched over to the VV ECMO. But this should be done on the individual basis and evaluating the patient carefully. Then, once the patient has tolerated the complete weaning trial, how do we wean the VA? Here, what we do, we keep reducing the flow and we bring down the flow to the ideal flow, that is around 1 to 1.5 liters per minute. We can do this over the hours. While in the VV ECMO, we were doing it over days. You can do this weaning for 3 or 4 hours or 6 hours, depending upon the patient condition. And when you have reached to a level of 1 to 1.5 liters per minute of flow, then possibly a patient is sustaining his blood pressure, his ejection fraction is fine, his echocardiography shows an improvement in the myocardial function, and the lateral mitral annular velocity and the aortic VTI is good. That means this is the time for trialing of ECMO, and we can remove the ECMO if the cardiac index is above 2.4 and there is no increase in the pulmonary capillary wedge pressure and in the central venous pressure. Then definitely you can think of taking off ECMO from these patients. Echocardiography has a very important role in both VV and VA ECMO, but in VA ECMO probably it has much more role as compared to the VV ECMO. Because if there is a failure, you have to see that why this ECMO reading has failed, whether it's a right heart is the issue or left ventricular issue, or there is a systolic or diastolic dysfunction. If there is a development of any new regional valve abnormality, or there is some ischemic mitral regurgitation which is not allowing bleeding to be as successful, there is a chances of there is some dynamic outflow tract obstruction, or sometimes patient is having a pericardial effusion and that is leading to tamponade, or still patient needs volume and that's why he's not maintaining his hemodynamic stability. So on ECMO, we bring down the flow to 20 ml per kg per minute, or roughly around 1 to 1.5 liter per minute per minute patient. And this what happens, you keep increasing the uh, patient's own blood flow and you keep reducing the ECMO flow. And this is what you do, you keep reducing it. And once your patient is sustaining, then definitely you can move to the trialing of for these VA or ECMO. So on ECMO, whenever we are planning of a trialing, the team needs to think of three things. Risk of continuing ECMO, you have to think. Risk of removing the ECMO, again, we have to make sure that this patient should sustain his hemodynamics if it is a VA-ECMO and should sustain the gas exchange if we are removing the VV-ECMO. And how much degree of support, because it is most of the time it is not possible that no support is required. So how much degree of support you are ready to accept once you are removing the ECMO. Method and duration of trialing off, this depends whether it's a VA-ECMO or VV-ECMO. VA-ECMO shorter, VV-ECMO longer, even whose trialing off can be for 1 or 2 days or 3 days. For VV-ECMO, usually it is a VA-ECMO 1 to 3 hours. So what we do, we increase the ECMO flow circuit in these situations, and so that there is a minimal risk of clotting. And what we do in the VA-ECMO, here we use the bridge during the VA-ECMO, which is usually it is clamp, but here we close the arterial and venous circuit limb close to your bridge towards the patient's side, so that, and we open the bridge. Now, only the blood will be circulating in the machine and nothing will be going to the patient. So patient, and now the patient is completely separated from ECMO, and so far ECMO is not disconnected from the patient. So after the bridge towards the patient's side, we put a clamp as close as possible towards the bridge so that this can minimize the risk of clot formation. And this clamping should be done for 10 minutes and then you disconnect it for 10 seconds. So that again the flow has been established that will further reduce the risk of clotting of the circuit. And whenever you are doing a trialing off, you should always keep in mind, now the machine is different and patient is different. So the activated clotting time on both the sides should be checked so that you can reduce the risk of clotting in the either on the patient side or in the ECMO circuit. So you clamp venous line, you open the bridge, and we clamp the arterial line. And you keep checking the ACT every 20 minutes, 30 minutes, and we do this trial off for 8 to 10 times, means roughly around, if patient is fine, you can do it for 6 to 8 trials for 1.5 to 2 hours, or you can increase it up to 4 hours, but do not prolong it for a long time. And during that time, you need to monitor the blood gases, you need to look at the venous oxygen saturation and lactate levels at the in different intervals, and continuous monitoring of the patient, mean arterial pressure, pulse pressure, for looking for any tachycardia, drop in oxygen saturation. And once it is maintained, you do an echocardiography to look for various parameters like a LV size, ejection fraction, to development of a new MR or aortic VTI and EDS. And once patient remains stable throughout, then you call the surgical team and plan for decannulation. And you again go back on the higher flows so that there is no clotting of the circuit. Now coming on the trialing of the VV-ECMO. In the VV-ECMO, we do a trialing of, we don't reduce the flow and we just switch off the sweep gas flow. Once you switch off the sweep gas flow, disconnect the sweep gas flow, that means only blood is flowing and there is no gas exchange taking place. So once you do this and you keep monitoring the blood gases of these patients, hemodynamics of these patients, and if it is well maintained, there is no drop in the urine output, patient work of breathing has not increased with a moderate ventilatory setting, that means your trialing off is successful and patient is ready for the decannulation. Okay, so how it is different, VV-ECMO and VA-ECMO. In the VV-ECMO, we switch off the sweep gas flow, while in the VA-ECMO, we are reducing the flow to a minimum and we are clamping off and clamping on our line for 10 minutes and then we flush for 10 seconds. And in the VV ECMO, after a certain extent, we do not reduce the flow. So there is no risk of circuit clotting. However, during VV ECMO, patient end and circuit end both has a risk of clotting. So you should be careful. The decannulation is usually done without any surgical intervention. You just need to remove the cannula and you have to put a pressure. While the VA ECMO, it should always be a surgical decannulation. Vascular surgeon should always repair the artery, irrespective of the method you follow to initiate the VA ECMO, whether it's a percutaneous cannulation or it's a surgical cannulation. So when we decannulate, when the blood gases is fine, hemodynamics is stable, you assemble the team where you call everyone and all the drugs to be given to the patient if the patient is on ventilators, adequate sedation, and all aseptic technique should be followed. And for a decannulation of VV ECMO, you just clean the skin, drape, and just you may need to put a horizontal mattress suture, and sometimes no suture is required. You just apply adequate pressure for 20 minutes, and then this bleeding will stop of itself. For the decannulation of the ECMO, surgeon has to cut all sutures, all lines to be clamped, and you have to give antibiotics. You do it surgically after repairing the arterial cannula to be removed first, and arterial repair has to be done for the VECMO for arteries. For the vein, you can just apply a pressure that will be sufficient to stop the bleeding in this patient. If we talk about the neonates, carotid artery is always tied up. In adult, we do a reconstruction of the artery and the older children. And if the ligation of the vessel has been done, there is always a risk of neurological insult. Post decannulation, always do X-ray, recheck the blood gases, hemoglobin levels, and other tests. Treat hyperparaxia because it is very common that there is a biofilm is released in the blood. Patient will be having the hyperparaxia. So especially in cases of VV ECMO, this hyperparaxia can be detrimental, and in VA ECMO it can lead to hypotension, while in the VV ECMO oxygen requirement will be much higher. So always treat the hyperparaxia. Always recheck ventilation that you are ventilating your patient adequately. Watch for any bleeding, hematoma, and pulse. On the side, you have done the arterial decannulation where arterial repair has been done. So to conclude, weaning is a gradual process for withdrawing the ECMO support. A thorough assessment must be done prior to decision of weaning. Weaning methodology is going to differ for VA ECMO and VV ECMO. In VA ECMO, it will be reduction of the flow, while in VV ECMO, it's more of the flow of the gases which can be reduced. A trial off should be attempted once you have achieved a successful weaning, and a thorough clinical, hemodynamic, and biochemical evaluation must be done both during weaning and trialing off. Ventilator parameters in both the cases, whether it's a VA ECMO or VV ECMO, must be readjusted prior to trialing off. For VA ECMO, it is a surgical closure, while for VV ECMO, you can just remove the cannula and you can apply pressure. What is more important? A good communication and integrated team approach for a successful decannulation. Thank you very much. If there is any question, I'll be happy to answer.